So we go ahead now to live case transmission from Hirslanden Klinik in the Schweiz, in Switzerland. And there's Dr. Corti and Gamperli with live case. So welcome. Can we switch now to Switzerland? Yes, we can see you. Just go ahead, guys.
Good. So welcome to Zurich. We are very proud to be part of your meeting today. We will do a very challenging case, in particular in the discussion how to proceed with this case. But first of all, I would like to introduce the people. Oliver Gamperli on my left, he will really be the ones doing the job. I will speak with you and discuss it. Then we have Johannes on the echo.
Hello.
We have Daniel in anesthesiology, and then we have a large staff, of course, as usual in the hybrid room. We have Ines here, Dennis, and then we have outside Adam and Silvana. So, and a lot of people, of course, helped us during the preparation. So we will start with the case presentation. Luca Oechsli will present the case.
Okay.
Thank you, Dr. Roberto Corti. I'm Dr.
Yeah.
Srinivas Kumar here. Before you start, I wanted to thank you. And what I was very impressed with the team, as we mentioned, is they follow the true heart team approach. Every case, before they take a decision, they all sit together and then practice the real heart team, and surgeons, the cardiologists together, everybody, clinical cardiologists sit together in the evening. I was very impressed with that, sir. That's how I thought we should have the presence of you in our TCT India meeting. And thanks for accepting. And we tried last year. It happened this year. I think we are very fortunate to have you. Sorry for interrupting. Over to you for your presentation. Thank you.
Thank you. So, Luca.
Okay, I start with the case, if it works. Okay. Yes, today's case, I give you a quick overview of this patient. He's a 75-year-old man who was referred to our clinics almost 2 years ago with severe mitral regurgitation due to B-leaflet prolapse in a mitral Barlow's disease, and then underwent minimal invasive surgery. And now, unfortunately, he represented with recurrent shortness of breath. So first of all, I will show you the TOE images taken after the procedure back in 2001. And as you can see, they put in a physio ring of 32 millimeters diameter and put in a neocord and also sutured the cleft of the posterior leaflet. And as you can see, the result was very satisfactory with almost no recurrent regurgitation. And now I show you the pictures taken 3 days ago. And here you can see the recurrence of this severe mitral regurgitation. And if you have a look at the valve, you can see that the anterior leaflet A2 has a little bit more prolapse than 2 years ago. There's also a small flail, and also the posterior leaflet is more tethering, resulting in this eccentric posterior jet. And on the left side, you can also see the gradient of something between 3 and 5 millimeters in atrial fibrillation. And you also note that this anterior leaflet is very large, measured almost 2.5 centimeters. So we discussed the case in our heart team. And as the patient already has had cardiac surgery, we opted for either transcatheter edge-to-edge repair or valve-in-ring intervention. And of course, both of these interventions have their pros and contras. For the TEER procedure, of course, the difficulties are to adequately reduce the mitral regurgitation without compromising the opening area. And as you've seen, the mitral orifice right now was already only 4 square centimeters. And then for the balloon involved valve-in-ring intervention, we performed the cardiac CT and simulated in systolic phase the implantation of a Edwards Sapien 29 millimeters valve. And here you can see that we calculated the neo-LVOT, and also there the predicted surface is 1.6 square centimeters. That is not very large, and also you have to think back to this very large anterior leaflet, and it's impossible to predict if it could lead to further outflow obstructions. So in the end, we decided to go on with transcatheter edge-to-edge repair with a Pascal device, and as a bailout strategy to be ready for a Wolfing ring after resection of the anterior leaflet.
So thank you a lot, Luca. As you see, we had a lot of discussion because we were really not sure, should we go for a Wolfing ring? For sure feasible. The problem is really the anterior leaflets, you will see it, is really very long. It's about 3.6 centimeter. And so the risk of occlusion also by starting with a lampoon procedure will be there. That's why we decided to go for a edge-to-edge repair. And in our clinic, we use about 50% mitral clip, 50% Pascal. I have to acknowledge that the device that we will use today is not allowed yet in India. It's not imported yet in India. We selected this device because the opening area is quite small. So we aim to treat the valve with just one device, and there will be a trade-off between reducing mitral regurgitation and inducing a stenosis. And in our experience, in this case, perhaps the Pascal is a little bit better. So now we proceed. We already perform a transeptal in order to speed up a little bit. I think Johannes can show you some echo images on the present situation. And I think you can appreciate there is a small prolapse that was already there 3 years ago after surgery, but at that time there was no regurgitation. The first thing that you have to look, of course, that there is no dehiscence ring, which is not the case. Here is a very eccentric, as expected, by a quite small flail and tethering of the posterior leaflet, probably due to a fibrotic change of the posterior leaflets after suturing the cleft. Good. So
maybe we could just ask you, do you believe this patient could be also be treated satisfactory by mitral clip, or this is device?
Sure. No, I think both devices are, in this specific case, probably equivalent. The only risk that I was a little bit afraid because of redundant valve is that using a large mitral clip like a XTV, perhaps we will further increase the gradient. We have already a gradient between 3 and 5 at present. Of course, it's a lot of volume. Problematic, but still I think it's a pity if we end up with a gradient of 7, 8, and that's why the difference are not big, honestly, but I think this device will have a little bit smaller gradient. And I will not go really into the details of the device. We will show you how we prepare it and how some small tricks how to go down to the valve, and in particular in patients that are already operated. So then we go, if you agree, we start, Olive. So now you see what we use a technology of overlay in the echo provided by Philips. Actually, we helped them during the last 10 years developing this technique, where we merge the two imaging technology. We can also do some 3D models that we can demonstrate perhaps later. You see that we put a marker. The marker is there at the septum so that we can manipulate the sheath without coming out from the septum. So Now you see, now typically we go a little bit on the right with the X-ray. You can appreciate the wall of the left atrium, and we start to going down with the clasp. Yes.
So important to highlight, because Pascal's not available here, some of the differences. It is a nitinol-based device where the arms are sort of come in. The grippers are, the mitral clip, the grippers are vertical along the length of the clip. With the Pascal device, the grippers are horizontal. The theoretical benefit of that is that they feel like it's less force on the leaflet and it's distributed across a larger segment of the leaflet. And then there's a spacer in between that maybe helps preserve some valve area so it doesn't bring the leaflets as close together. But I think in the majority of cases, they're both interchangeable. The delivery systems are very different though, whereas the MitraClip delivery system is keyed. The Pascal is not keyed. It's just basically two independent catheters.
So I hope you could appreciate. Thank you a lot for the commentary. I didn't want to go into the detail. We choose a small device, a Pascal Ace, with a smaller spacer. The normal Pascal has a large spacer. Again, because we wanted to reduce the risk of stenosis, we choose the smallest one. I hope you appreciate how we go down to the leaflets. Of course, you have the ring. You can use the ring as a reference. If you don't have a ring, we use really quite often the model that you can appreciate there, or we go to the right RAO, sometime a little bit cranial, so that you see how the catheter comes down without touching any structure. What is important, because of course the ring is protruding a little bit in the atrium, you really need to see that you are not touching the ring. So now we are centered about in the valve. The first things that we will do is looking with a 3D. Just stop if you have any question. Now we are starting to center the device in the middle of the valve. We will aim A2, P2 a little bit more medial, because the flail is a little bit starting from medial, and that's why the jet is from anterior flail going to posterior all around the atrium. Posterior a little bit.
Could you tell us how the operator is feeling this crossing through the valve? Do you have some?
Is quite similar. We always cross, in particular if you have a small valve, we always cross in a closed position. The feeling is quite similar. The tactile feeling is similar to what we have with the MitraClip. Okay. So the device is just, instead of using knobs to go medial, lateral, or anterior, posterior, we just have a device that's similar to the Sapiens 3 device for TAVR, that you just turn the handles here. So here you can, if you turn it, you go medial. If you turn it back, you go a little bit lateral. You can flex the sheath, and then you have the system is quite similar. You open the arms, similar to the most modern MitraClip version. You see it now. I am slowly opening. We will do first the alignment. We will do first the alignment. You see the alignment is not correct. You see, even though it's the smallest device, it looks huge within a reconstructed valve. So now go in 3D, please, Ioannis. So now we rotate a little bit clockwise, very similar to what you do with the MitraClip. Voilà. I think
looks now very nice.
quite nice. We are still not really medial. We are really in the middle of the valve, but I think to start is more than adequate. Now we check the grasp. So what in a mitral clip, we can, sometimes we see it in the video. So this is the anterior one. So the other one is the posterior one. So the dark one is posterior one. And now we check again. We check again. Yeah, I think we can grasp simultaneously. Now we change again to a position that we think is ideal to be perpendicular to the valve. In at present is RAO 54 and a little bit cranial. We use the model for optimize the implantation, but otherwise, you can try to set up with the silhouette of the heart, always pointing to the tip of the left ventricle. So we close it, then do an X-ray.
So, I mean, I was just looking up, the 32 physio ring has an AP dimension of 21, which is roughly what this Pascal device is with the arms, like 10. So that's why it looks big, but that's just because the ring, and one of the challenges in a ring often is you downsize, and also the posterior leaflet is almost eliminated. But here there's a good posterior leaflet to move.
Yeah, the posterior leaflet is quite long. It's quite long, but it's tender.
And also sometimes the imaging becomes really challenging with these rings, but in this case, you can actually see the leaflet quite nicely. That makes
we were very happy to. You even see sometimes, depending in the cut with the echo, sometimes we see even the chorda, the neochorda from the anterior leaflets, which is still there. It didn't rupture. Sometimes you have rupture or a disconnection of these new leaflets, which is not the case. Good. If you agree, we penetrate the valve and we control OLS. You see now we choose a projection that we are perpendicular to the device. We always do it also with the mitral clip, so that once we go down, you see now we are going down toward the apex. We hope that it will not rotate. So now it's okay. We go a little bit more. We have some bubbles, and this is a good, I think, a good, a good system to be sure that you don't rotate. We don't like to rotate a device within the ventricle. Also, if you have space, because you cannot evaluate really the cord and so on. So now we are happy. We are a little bit too lateral. Ollie, just try to center. Then we have time. Echo, please look at 3D. We look again at 3D reconstruction to see. We have plenty of time. We are almost done. We were faster than Eberhard. So we speed up a little bit because the program is quite long. If we are successful, we will close the left atrial appendix. We will have to do some electroconversion. We want to optimize the result at the end. We spend so much time in discussing the case. Good. I think now you see the echo. I hope you can appreciate the small prolapse. So we are just lower than the prolapse. Now it's time to open it. Again, it looks large, but as you say, is a little bit an impression. Good. The orientation.
May I ask you between how is the hemodynamic situation of the patient? This is a very safe procedure.
It's similar to the mitral clip. It's very stable. You see, we take time. Actually, we have a V wave of about 40 at the beginning. Now it's difficult. We have the possibility to measure it through an accessory line. And now when we are moving it, we have some disturbance, but we will show you the V wave at the end. I think we are quite happy. You can appreciate the anterior leaflets, which is very long, that goes till the tip of the catheter. The posterior, difficult to appreciate. Now we will improve it later. Now we looked at the clocking again. you see, similar to what was discussing in the previous talk, how to optimize the results in TAVR. Also here is extremely important to have a good alignment. So you have to be perpendicular to the valve. And I think if you look at the X-plane imaging in the echo, I think we achieved. There are, of course, always some movement, respiratory movement. If you want to go a little bit more medial, then you stop breathing and the catheter slowly goes to the medial part. Otherwise, when the patient is so stable as it is at present, then you use a small tidal volume and you don't have huge movement.
Can we see the clocking? The clocking?
So the clocking, yeah, just change a little bit.
You mean the previous image?
I think it's good.
No, now the clocking now, please. Reduce the gain a little bit.
Gain down. So we try to check again the clocking of the device.
I think it's
very similar to the mitral clip. I think we are good. We are perhaps a little bit too the middle of the valve. A little bit more medial would be fine. Yeah. I think if you agree, we try to grasp once here. I close a little bit.
I think we are quite medial on the floor, probably.
Now it's good. I think we try to go with both. You see how they move. I went down with both clasp, the gripper in mitral clip. You see how they move, both. So they are both for sure in. I retract the catheter a little bit. And then we start closing. Perhaps we can do some color on echo. We do very slowly. The V wave already reduced. So, and go down a little bit.
This is good.
Voilà. So you see quite a controlled procedure, no stress at all. V wave, we have a V wave. It's in atrial fibrillation, so it's a little bit variable, but it's between 15 and 20, 18, 20. And you see typical, typical things that you see if you have a good results. If you have an acute increase in peripheral arterial pressure, you have a decrease in the V wave, and sometimes an increase in smoke in the left atrium. If you have smoke in the left atrium, the first thing is checking the gradient. If you have really a lot of smoke. Remember, we had a gradient between 3 and 5. 5 is acceptable. More than 5 is not. We have a gradient now of 3, which shows probably that we adequately reduce mitral regurgitation. What I still don't like, we have quite a movement of the anterior leaflets, but the anterior leaflet was 3.6 centimeter in length. So I think we assessed with echo. You see the echo. So the echo, I think, is quite good. We have still a very small jet, but honestly, after all the discussion that we had yesterday and the day before, I would have.
Can you estimate the area now?
Yeah, we pre-estimate the area. So what we always do, we look at the 3D and then we simulate the decrease in the area. We will measure it now, but we expect, similar to what you expect with the mitral clip, a reduction between 40 and 50% of the area. So it means that in this valve that was about 3.6 square centimeters, we will go down till 2 centimeter, 1.8 centimeter should not be smaller than 1.5 centimeter. But
that's clear.
But I think You see the device is there where we wanted to place it.
At
It
the
may-
moment, regurgitation is really minimal. What do
It's
you-
minimal.
And
And,
hemodynamics
you
is
know,
also
it's a reconstructed valve, honestly. And in a reconstructed valve, you have the optimal situation. You have already a ring there. This was a quite small, a small flail. And the combination of the small flail and the retracted posterior leaflets was really a bad combination for the patient that that actually had a severe dyspnea. Now, the only problem that I am still thinking about is if we have to
definitely.
close the left atrial appendix, because we have quite a smoke situation.
But I think we can release them.
Yeah. First of all, we have to evaluate the anterior leaflets. I think the posterior leaflets, because was tether, is for sure good. The anterior leaflets, for sure, is in. This is not a big deal. Ioannis, you can measure how many millimeters between the ring and the device. So we can estimate how much leaflets it's inside.
Do you perform this measurement routinely in every case or just in this?
No, just if we are not sure, honestly. Honestly, if you know, it's just one possibility. If you are happy and you think you put the device in the right spot, you have a good hemodynamic results, then I think. And you see the anterior leaflet is still moving, but honestly, I think he is okay. I think it's okay.
I think so too,
Yeah,
because
no,
it's a very
yeah.
large leaflet. It's going to be difficult to grasp
Yeah.
all of it.
You see, it's 1.3, let's say 1.4. We measured 3.7. It's difficult to differentiate because you have, of course, on the tip, you have the neocord, but I think it's an acceptable result. I think if you agree, we implant the device and then we continue with the left atrial appendix closure. Are there any comments otherwise?
This looks like a really good result. I mean,
Yeah.
trivial to mild, the location is perfect, no medial leak related to the device. And I think the imaging that we've seen seems there's plenty of leaflet in both anterior and posterior. So the chances of clip detachment later on would be very low.
Very low, yeah.
This looks really
Yeah.
good to me.
Now, as long as you visualize the leaflet to the base, to the base of the V, then that's the best you can do as much as you can. Well, I missed the gradient. What was the gradient?
3.
3. 3 was even lower than before because now we abolished the regurgitant volume. So there is no big flow through the valve.
But I do think this motion of the anterior leaflet, this is something that looks different with the Pascal device than with the MitraClip. Because I think the MitraClip brings it actively, it's an active lock, brings it in. You see less of this. This is coming over the thing. That's normal. I think this is not something I'm worried about in a case like this.
Finally, we believe you are very exact in position and you can go ahead.
Good. Then we remove the lines. We have similar to the MitraClip. You have to remove the lines. Small different here. We can do it a little bit faster. The MitraClip device, don't forget, always do it very slowly. Not the device will open. So one line is out. Second one. Perhaps one of the advantage of this device in this new generation, this is the precise, really the last generation of this device, is, as the name says, precise. It's quite precise. At the beginning, we were, in the last few years, we were not very happy because it was a little bit a floppy device. You had the impression sometimes you move and it takes a little bit and then you move the device. And with the new one, you are really very precise. You move very slowly. And once you implant it, normally the device stays exactly there where you implanted. So you don't have even though in this case we have a large anterior leaflet with a prolapsing anterior leaflet, I hope that we will be able to demonstrate that we will not have this kind of rocking of the device. So now we are already implanting, so we turn this hard wire to release the device.
Pull a bit. Yeah.
So, and now we can retract the whole things. And you say, it's moving a little bit more than normally, but I think it's acceptable. For us, so a long leaflets, we remove the device and then we check again. We don't have a lot of possibility because I don't think we have space for an additional device. So.
Aber
Hemodynamically is fantastic. Good, we have a low pressure now. We will increase the pressure, but we will, slowly. So now what we do, we keep the sheath in. Problem is this sheath is a little bit too long to proceed with directly with a amulet device. It means we will exchange the guide. Perhaps we can demonstrate if the camera can show you. We modified a few years ago the figure of 8, which is extremely helpful to close a large hole in the vein. We modify just turning 90 degrees. So we go close to the catheter, wait, that you can demonstrate. So along the catheter and not crossing the vein. So we started 5 years ago with a small modification. We actually published in the Indian journal, Indian Circulation Journal, a few years ago. Since then, with more than 400 cases, we didn't have a single closure of the vein, which I think is probably shows a lot of luck. Yeah. So we go along, big bite, similar to the normal things. Then we take so we normally take a big needle. You don't see it. But well, you need to understand we go along the vein, so crossing outside the body. So we go through the skin along the vein, then we cross over the catheter and then again along the catheter. You feel the catheter, so you will not be within the vein. So the advantage is that we can remove the large sheath and reducing bleeding. Adam, can you take out the excellent.
Do you plan to close appendage as well?
Yeah. If we have another 10 minutes, we will do it. So perhaps you can see.
This looks really good.
Ja, mit der Größe, ja.
Durchleuchten. So you see in the overlay, you see the catheter, the wire. We are already going over. Stay like that, Ioannis, that we see the warfarin reach. So we go over the warfarin reach. I remove the catheter. Very controlled situation. Don't pull too much.
No.
Now we exchange for vorbereiten. So in the meantime, we will prepare the device. In this case, we have an anatomy which is in echo looks a little bit like a windsock because we evaluate the patient for valve in ring. We had a CT. And actually, in the CT is a completely different anatomy. It's really a chicken wings with, but a quite round orifice. And so excellent.
Hatte.
So we need We need these things. Slowly. That's good. So we are in. We can remove. And also in this case, we just use imaging. No contrast agent, no injection. We didn't even prepare the injector. So we, Oli?
Mhm.
Yeah.
Depends on how much.
Mhm.
Sorry.
Probably
Oh.
not.
And I think in this anatomy, you can choose different
the
device.
wave, no?
You can choose different device. We decided because it's not so deep, we decided to use a amulet to a 28. We had a mean diameter in the CT of about 24, if I recall well. So we oversize a little bit.
Sure.
You can see we flash it. Then normally I remove the syringe so that you don't have, you can manipulate a little bit better. And again, Luca perhaps show that we show the overlay. In this case, overlay really help us a lot. We will do with the ball technique, so we'll go out from the catheter. We choose already a projection which is very similar to the projector that we use for the Pascal. I will stay there. Yeah. So like this. Typically, when we advance the device, then it stretch a little bit the sheet. The company is coming with a beautiful sheet that you can control the angulation. So it's, I really think a beautiful improvement, because then we will have an optimal alignment to the orifice. So in this case, not 3D, keep it in 2D because we really can appreciate quite well. So we go out a little bit. We try to do a no-touch technique. So we develop the first part, balloon. Okay, this is the ball technique. We go a little bit deeper. You see the circumflex in the, yeah. Here you need really a little bit more of ends. And then importantly, we develop very slowly the device. Very slowly the device. Because it jumps always a little bit, in particular this large device. So we wait, we wait, we wait. Now comes the barbs. I think you can, probably it's difficult to appreciate. Voila, very slow control. Voila, implantation. It's quite good. You see we are quite deep, but I think it's better than, and now we are just after the circumflex with the lobe. And now we pull now we keep the wire. We pull the catheter.
It is possible to have 3D picture.
It jumped out, sorry. We go a little bit deeper because it jumps a little bit out. We want it to be deep. We develop again.
And we see 3D echo, maybe.
You don't see the echo? You don't see the echo? Sorry.
We see at the moment standard echo.
No. This is not good. Luca, can you show echo nav overlay? Well, it's not very deep. We do an filming?
No, it's quite well compressed.
Yeah, we have a good compression. Honestly, I would have loved to have it a little bit deeper inside, but we do a little bit enlargement, zooming in,
I think it's
and
quite
we
good.
optimize the. Yeah.
It's well
What do you
compressed.
think? I think is we have some compression from the lobe in the disc is quite good. It's really at the ridge and coming down, not touching the ring. So I think it's okay. Huh?
Yeah,
You
this
keep it a
looks
little
like,
bit. Yeah.
no, this looks like a good location to me. I think it's not sitting too proud. It seems well oriented. A good separation between the disc and the lobe.
I agree. Of course, you know, it's always nice to have the lobe a little bit deeper, a larger separation between the disc, then you know that you are really on the safe side.
But it's well compressed.
Because if it's embolized during the first 24 hours,
Hast du nochmal das
it
Plan?
will not go through the mitral. That's why we have to be a little bit sure that it will not embolize. In the meantime, that we wait a little bit that it develop a little bit better. Johannes, you can show the result of the mitral. Now we have a blood pressure about between 140 and 150 systolic. I will show you perhaps, I don't know if you can see the hemodynamic. Yeah. I think the device remain quite stable. Right? We do a larger view that you can see a little bit. Good overlay, so X-ray. So you see the device, the Pascal device is not really clocking a lot. Do a little bit more of fluoro. It's not clocking a lot. We have some minor, yeah, we just say mild regurgitation left, but I'm happy with the results. Check again the gradient, because
what is mechanism of this regurgitation finally?
Yeah, the regurgitation was by there is anterior prolapse that was prolapsing over the tether posterior leaflets. We can show you the picture of the beginning, perhaps. So the gradient is really not a problem.
To be honest, at the moment you can just leave it. What can you do now? I think.
Yeah, exactly.
Right, we can accept this.
Yeah, but it's just to show you that the result was okay, that we are happy. Agree. Electroconversion? Yeah.
Nein, weißt du nicht, was das los war?
We implant in the meantime the the LAO closure device, and then perhaps we can show you the mechanism, the images. I didn't know how much time we have for the live, because Eberhard was a little bit long in the presentation, so I was a little bit speed up the procedure. So if you agree, we show you, we take the catheter out, we show perhaps the hemodynamic.
I think that this looks like a really good result to me. So I think in the interest of time, we'll probably move on. I think just a wonderful demonstration of the Pascal and the amulet, and clearly a tricky anatomy with a ring and prior surgery. So my congratulations to your team.
Congratulations and thank you for
sharing this with us.
Thank you.
Okay.
Thank you.
Bye-bye. Thank you.